Morning, my dear students. Today we are going to discuss about tooth hypersensitivity. Tooth hypersensitivity or dental hypersensitivity is a common clinical condition that frequently associates with the exposed dental surfaces. It can affect patients of any age group and most commonly affect the canines and premolars of both the arches. Now, the common terms that we are used to refer this tooth hypersensitivity are dental hypersensitivity, cervical hypersensitivity, root hypersensitivity, and cemental hypersensitivity. So, what's the definition for a dental hypersensitivity? Dental hypersensitivity is defined as a sharp short pain that arises from an exposed tendon in response to stimulus, typically thermal, chemical, tactile, or osmotic, and which cannot be ascribed to any other form of dental defect or pathology. This definition was given by Fowler in 1997. Many theories have been suggested to help explain the mechanism involved in the etiology of dental sensitivity. These theories are neural theory, odontoblastic transduction theory, hydrodynamic theory. Now, coming to these theories one by one in detail, neural theory, first one, neural theory, is the neural theory attributes to the activation of nerve endings lying within the dental tubules. These nerve signals are then conducted along the parent primary afferent nerve fibers in the pulp and onto the dental nerve patches and then onto the brain. Neural theory considers that entire length of the tubule contains three nerve endings. So this is a schematic representation of how neural theory works. You can see this nerve endings in the odontoblastic cells, and these correspond acts on this nerve stimulus, that is your called stimulus. It activates the nerve impulses, nerve fibers, and these impulses are carried on to the brain and is interpreted as pain. Second one is the odontoblastic transduction theory. This theory assumes that odontoblastic cells extend into the periphery and stimulus initially excite the processes or body of the odontoblast. Membrane of odontoblast may come in close apposition with that of nerve endings in the pulp or in the dental tubule, and the odontoblast transmits the excitation of these associated nerve endings. However, in the most recent studies by Thomas, it indicates that the odontoblastic processes is restricted to the inner third of the dental tubule. Accordingly, it seems that the outer part of the dental tubule does not contain any cellular elements, but is only filled with dental fluid. So these two theories that we discussed are not used. And nowadays, most widely accepted theory is the hydrodynamic theory. This theory proposes that a stimulus causes the displacement of fluid that exists inside the dental tubule. And this displacement occurs in either outward or inward direction, and mechanical disturbances thus activate the nerve endings present inside or in the tendon or pulp. So this is what really happens in hydrodynamic theory. We have these dental tubule cells. It consists of dental fluids. And when stimulus like thermal, evaporative, or chemical acts on these exposed dental tubules, that causes the change in rate of dental fluids. That creates or that generates an action potential in the interdental nerves. The action potential passes onto the brain and thus causes pain. Brainstorm was the first to propose this theory. He suggested that the displacement of tubule content is rapid enough to deform the nerve fibers in the pulp or pre-dendine or to damage the odontoblast cells. Both of these effects appear capable for producing the pain. Currently, most investigators accept that tendon sensitivity is due to the hydrodynamic fluid shift, which occurs across the exposed tendon with open tubules. This rapid fluid movement in return activates the mechanoreceptors or nerves of air delta group in the pulp. Matthews et al. Noted that the stimulus such as cold causes fluid flow away from the pulp, producing more rapid and greater pulp nerve response than those such as heat, which causes an inward flow. This certainly explains the rapid and severe response to cold stimulus compared to slow, dull response of heat. Dehydration of the denine by air blast or absorbent vapor causes outward fluid movement and stimulates the mechanical receptors of the odontoblast, causing pain. Prolonged air blast causes formation of protein plug onto the tendon tubule, reducing the fluid movement and thus decreasing the pain. Pain produced when sugar or salt solutions are placed in contact with the exposed tendon can also be explained by tendinous fluid movement. Tendinous fluid of relatively low osmolarity, which has a tendency to flow towards the solution of higher osmolarity, that is like salt or a sugar solution. Now this is the representation of what we have discussed in the previous slide. That is, if a burst of air or cold stimulus acts on the tendon tubules, that causes the outward flow of the tendon fluid. And in case of heat, it causes the inward flow. And like hypoosmotic solution, like your salt or a sugar solution, that will also causes the expansion and contraction and outward flow of the tendon tubules, tendinous fluids. So these responses are then carried away by afferent air delta fibers onto the brain. Coming to the incidence and distribution of tendon hypersensitivity. Now, if we check the intraoral distribution, we can see hypersensitivity is most commonly noted in buccal cervical zones of permanent teeth. Although all the tooth types may be affected, canines and premolars in either jaw are the most frequently involved. Right-handed toothbrushes in tendon hypersensitivity is greater on the left side of the tooth compared with the equivalent contralateral teeth. Incidence. Most sufferers range from 20 to 40 years of age, and the peak occurrence is found at the end of the decade. In general, a slightly higher incidence of tendon hypersensitivity is reported in females than in males. Reduced incidence of tendon hypersensitivity in older individuals reflects age changes in the tendon and the dental pulp. Fluorosis in tendon, that the laying down of secondary tendon and fibrosis of the pulpal wall would all interfere with the hydrodynamic transmission of stimulus to exposed tendon. Now, coming to the etiology and predisposing factors. The primary underlying cause of tendon hypersensitivity is the exposed tendon tubule. Tendon may be exposed by two proximal, that is either by loss of covering periodontal structures, that is by gingival recession, or by the loss of enamel. The most common clinical cause for exposed tendon tubules is gingival recession. Now, gingival recession will do the removal of the cemented layer that in turn exposes the tendon tubules and dentin. The tendon tubules, exposed tendon tubules will cause the depolarization of nerve endings of odontoblast and will result in pain. Loss of enamel. Loss of enamel can be mainly due to the attrition, that is the tooth-to-tooth contact, or wear, abstraction, abrasion, or erosion. Abstraction is the tooth loss or tooth wear due to contact of tooth with another object. Abstraction is again repeated lateral occlusal forces that act mainly on the cervical region of the teeth that will cause the loss of enamel. And erosion is chemically induced by certain chemicals. Coming to the differential diagnosis, dental hypersensitivity is perhaps a symptom complex rather than a true disease and results in stimulus transmission across exposed dentine. A number of clinical conditions are associated with dentine exposure and thus may produce same symptoms. This involves your dental caries, your fractured enamel exposing the dentine, cracked tooth syndrome, fracture restoration, post-restoration sensitivity, high points in restoration, pulpal pain, and bleaching sensitivity. So we have to look for certain diagnostic hints to differentiate between dental hypersensitivity and the rest of the conditions. Tooth hypersensitivity differs from dental or pulpal pain. In case of dental hypersensitivity, the patient's ability to locate the source of pain is very good, whereas in case of pulpal pain, it's very poor. The character of pain does not outline the number. The pain is intensified by thermal changes like heat or cold, and also by osmolarity dependent solutions like sweet and sour. Intensity of pain is usually mild to moderate, and the pain can be duplicated by hot or cold application or by scratching the dentine. Pulpal pain is explosive, intermittent, and throbbing and can be affected by hot or cold. Now, what's the treatment modality for this hypersensitivity? So, the management of hypersensitivity involves, it's a well-known fact that hypersensitivity often resolves without any treatment. It is probably related to the fact that dentine permeability decreases spontaneously because of the occurrence of natural processes in the oral cavity. The natural processes contributing to dentine desensitization are formation of reparative dentine by pulp, obturation of tubules by the formation of mineral deposits like dental sclerosis, and calcium formation on the surface of the dentine. Two principal treatment options are available. First one, to plug the dental tubules, preventing the flow. Second is to desensitize the nerve, making it less responsive to stimulus. Home dental devices. After proper diagnosis, dental hypersensitivity can be treated simply by inexpensive home use of desensitizing dent devices. These dent devices contain tungsten fluoride, that is 10% tungsten fluoride. Desensitizing dent devices are found effective in relieving the pain of tooth hypersensitivity. Again, potassium nitrate dent devices are found to elevate pain related to tooth hypersensitivity, and the percentage of potassium is somewhere around 5% potassium nitrate. Again, fluoride dent devices like sodium monofluorophosphate dent devices are effective mode of treatment of this tooth hypersensitivity. In of its treatment procedures, it includes what's the rationale behind this therapy? It's that according to the hydrodynamic theory of hypersensitivity, a rapid movement of fluid in the dental tubules is capable for activating intradental sensory nerves. Therefore, treatment of hypersensitive tooth should be directed towards reducing the anatomical diameter of the tubules, obliteration of the tubules, or surgically cover the exposed dental tubule so as to limit the fluid movement. So the three rationales are, in office treatment procedure for hypersensitivity, we are targeting the healing of exposed dentine or tooth surface, obliteration of the dental tubule, and to cover the exposed dentine by the means of surgical methods. Treatment often to reduce the diameter of dental tubule. This involves the formation of smear layer by burnishing exposed dentine surface. Smear layer consists of small amorphous particles of dentine, minerals, and organic matrix or denatured collagen. Application of agents that form insoluble precipitate within the tubule and impregnatation of tubules with plastic dressings. Application of dental bonding agents to seal off the tubules and covering of the dental tubules by surgical means also helps to decrease the hypersensitivity. We can use varnishes and corticosteroids as well. Varnishes, open tubules can be covered with a thin layer of or thin film of varnish, thereby providing a temporary relief. Varnish such as Kothamangalam can be used for this purpose. Furthermore, sustained relief, a fluoride-containing varnish, Duraflor, can be applied. Corticosteroids. Corticosteroids containing 1% prednisolone in combination with 25% paraphenol, 25% metaphynyl acetate, and 50% gum camphor also found to be effective in preventing post-operative thermal sensitivity. Certain soluble salts react with ions in the two structure to form crystals on the surface of the dentine. To be effective, crystallization should occur 1 to 2 minutes, and the crystal should be small enough to enter the tubules, must also be large enough to partially obturate these tubules. Some of the examples of these soluble salts are calcium oxide dihydrate crystals, silver nitrate, zinc chloride, and formalin. Calcium oxalate dihydrate crystals are found when potassium oxalate is applied onto the dentine. These crystals are very effective in reducing the permeability. AgNO3 or silver nitrate has the ability to precipitate protein constituents onto the odontoblastic processes, thereby partially blocking the tubules. Zinc chloride or potassium ferrocyanate, when applied, is highly crystalline and covers the dental surface. Formalin 40% is topically applied by the means of cotton pellets or orange stick onto the teeth, and it has got no staining property. So this is a diagram of the scanning electron microscopic image of occluded dental tubule. Picture A shows us the open dental tubule and B occluded dental tubule. Calcium compounds have been popular agents for many years for the treatment of hypersensitivity. Exact mechanism of action is unknown, but evidence suggests that these compounds may block dental tubules and promote the formation of peritubular dentin formation. Only increasing the concentration of calcium ions around the nerve fibers may result in decreased nerve excitability. So calcium hydroxide might be capable for suppressing the nerve activity. Fluoride compounds. Dubovsky was the first to propose the use of sodium fluoride as desensitizing agent because the dental fluid is saturated with respect to calcium and phosphate ions. Application of sodium fluoride leads to the precipitation of calcium fluoride crystals, thus reducing the functional radius of the dental tubule. We can also use acidulated sodium fluoride, sodium silicofluoride, and stannous fluoride. Tungsten fluoride. Studies have also shown that the topical application of tungsten fluoride, concentrated tungsten fluoride on the braided dentine surfaces produce a deposit of tungsten that penetrates dentine to a depth of 10 to 20 micrometers and extends onto the dental tubules. Oxalates. Oxalates are relatively inexpensive, easy to apply, and well tolerated by patients. Potassium oxalate and ferric oxalate solution make available oxalate ions that can react with calcium ions in the dental folds to form insoluble calcium oxalate crystals that are deposited in the matrices of dental tubules. Dental adhesive resins. The objective in employing these resins is to freeze the dental tubules to prevent pain producing stimulus from reaching the pulp. Gluma, that's the dentine bonding agent that includes your glutaraldehyde primer, and 35% HEMA, that is hydroxyethyl methacrylate, provides an attachment to dentine that is immediate and strong. Lasers. The treatment of dental hypersensitivity can also be carried out by lasers. Lasers used in the treatment of hypersensitivities are divided into two, that is your low power output, low level lasers, that is the helium neon lasers, and gallium aluminum arsenide lasers, or middle output power lasers, that is Nd:YAG lasers, that is your niobium aluminum garnet lasers or carbon dioxide lasers. The lasers effects are considered to be due to the effect of sealing dental tubules, nerve anesthesia, or placebo effect. Ceiling effect is considered to be durable, whereas nerve analgesia or placebo effects are not. So this is the summary of what all we have discussed so far. Management of tendon hypersensitivity. It can include home care to identify this. It includes tungsten chloride, potassium nitrate, or fluoride identifiers. In-office treatment using varnish and corticosteroids. Treatment that aims at partially obturate the canals or dental tubules are burnishing of tendons, silver nitrate, zinc chloride, formalin, calcium hydroxide, containing compounds like calcium hydroxide, dibasic calcium phosphate, fluoride compounds like tungsten fluoride, tungsten silicofluoride, gas fluoride, or by the means of ionotophoresis, tungsten chloride, and potassium oxalate. You can also incorporate tubule sealing agents like respiratory resins, tendon bonding agents as well. You can also use lasers for the treatment of tendon hypersensitivity. And all the treatment should follow proper patient education, dietary counseling, good brushing techniques, and diet control measures. So to conclude, patient education is very important and involves dietary counseling, teaching toothbrush, proper toothbrushing techniques, and measurement for plaque and calculus control. Treatment of tendon hypersensitivity should be on a regular basis, and this treatment should initiate with home therapy and then continue with the complementary therapies. It is recommended that follow-up visits should be organized for all the patients after undergoing periodic treatment. So if you want to know more about hypersensitivity, its diagnosis management, you can follow this article, and majority of the content is I have taken from this article as well. So that's all for about the dental hypersensitivity. I hope this topic is clear. Thank you.